or these thoughts really. And this is, I suppose, keeping along the theme of paediatric healthcare. My background is in paediatric oncology nursing. I worked for a long time as a bedside nurse and then moved into sort of research. And the reason for that was really, I suppose, some of the questions. Oh, it looks like I've got timings on this. Can we? Yeah. It's what happens when you tick that box and it gets timings on it.
Please carry on also at 2 seconds.
Yeah, the impetus for my research really has been informed by that clinical practice and questioning why we do things the way we do, and are there better ways to do things. And a lot of my focus has been around symptom management and communication and the way that we pass information to families. So as healthcare professionals, we've got, well, there's lots of timings on there. We have lots of information and really valuable resources that families don't always get, don't get that information in a way that they can understand. So sort of a bit of a background of where my work comes from. It's usually just a little.
Yeah, sorry, it's just frozen temporarily.
Okay. All right. So I'll just move along so that we don't eat into our morning tea time. So one of the tools that I'm really interested in looking at is something that's called patient-reported outcome measures. You hear the acronym used PROMs all the time, PROs or PROs, and I'll try not to use too many acronyms because I'm aware that, you know, this is another way that it gets confusing for people when there are so many different acronyms used in healthcare, and certainly even PROs in oncology world, that can also mean to do with radiation and nothing at all to do with measures. So when if I use the term PROs or PROMs, I'm talking about a measure that's been designed, and it should be designed in consultation with patients or with consumers so that it measures outcomes that are important to that patient. We know that these sorts of tools can be really useful in communication in healthcare. They're one way that we can use a structured process to obtain some information or share some information between the patient and the clinician. We know, and we've heard today, there's so many barriers around communicating in healthcare. We've got structural and process barriers, and we've got all our interpersonal issues, cultural issues. There's so many different barriers there. And PROs or patient-reported outcomes are one tool that we can use to slot into our whole system of care and the way that we communicate, and try to look at ways of improving some of those processes. But when it comes to looking at pediatrics, our measures get a lot more complicated. In the adult world, PROs or PROMs, patient-reported outcomes, are used widely in healthcare, and particularly in cancer care. They've now become really commonplace, and these structured sort of questionnaires are used to measure things like symptoms or quality of life. And they're developed for all sorts of different conditions, not just cancer, and they provide a way for a patient to report on where they're at any point in time with their healthcare. So my interest has been around symptom management, because I come from nursing and symptoms are kind of our bread and butter.
I'm sorry, you have some really resilient transitions. I don't
Try something.
Yeah, please.
Yeah. Yeah, okay. This is what happens when you tab through the slides really quickly. And they all seem to, yeah, anyway, apologies. Keep it like that. So
What slide do you want to be on?
I'll stay on that.
Okay.
That one up there. Yeah, so just to go back, so the PROs are used at that micro, meso, and macro level. So at that micro level, they can be really helpful for communicating between the patient and their clinicians to pass that information in a structured way that provides some language for the patient to say, well, this is how I'm at today, and that provides information the clinician can then use to inform their clinical care. So they might intervene if the patient, say, for example, has elevated pain or nausea or some sort of psychological distress. The clinician can then address that. At the meso level, it can be used to compare a group of patients and look perhaps at how a health service is functioning. And then at the macro level, we can use all of these data and aggregate it up together and really look at, from a systems level, how is the healthcare system responding to this particular condition? How are we doing? Can we use this information for policy? Now I'm going to have the same issue with going forward. Okay, so we've used PROs a lot in clinical trials, lots of benefits reported, but this all comes from the adult world, where we know that they're demonstrated in a trial situation to enhance communication, provide that shared language, and right down to improving decreasing hospital emergencies and being cost effective. But we have very little information about how this might work in pediatrics, and there's a number of reasons for this. And so I just want to unpack that a little bit of why it's a little different in when we're talking about children. In some of my work, we have taken a PRO that has been developed in consultation with children around their symptoms. And these are some of the example questions that come from the measure that we're using. It has got quite a lot of psychological symptoms in there. So we ask, how much have you been bothered today or yesterday about changes in the way your face or body look, about feeling tired, problems with thinking or remembering things, or feeling disappointed or sad. And so it provides words for that young person for something that they might not otherwise speak about, that they might not otherwise bring to the table. When we've asked our families and children what they think about using these sorts of structured ways of communicating, they're positive. So those items come from a tool called the Speedy. It's got 15 different items, and it's developed particularly to report on cancer-related symptoms. We can see here one mother reports that, well, I thought it was normal if he was nauseous and that he wasn't going to eat. I thought that was it. I didn't realize we could do something about it. So it highlights that, if a child doesn't complain and a parent doesn't think to act and a clinician doesn't ask, that symptom may go completely undetected and untreated. And we can do better than that. We know how to control nausea. This shouldn't be something that the child needs to be overburdened with. In the yellow there, answering questions about my symptoms makes me feel more secure about how I'll be treated in the future. So, this indicates that this provides some empowerment for that child, that they feel more in control. They're reassured that their healthcare is going to be something that's going to be well managed. In the red, although I would have talked about these symptoms anyway, it helped me to focus. It helped call attention to other problems such as mobility. So highlighting again that in a clinical interaction, you may only focus on one or two problematic symptoms, but having this structured process can help bring some of those other ones that might be grumbling along into the forefront. Part of my anxiety is I don't like to bother people. I worry about bothering them. But if I'd been directed to call, that would help reinforce it's okay to be calling because of this. So again, just highlighting that these are things that clinicians do want to know about it, because we can intervene. And if we're able to intervene early, then that's then that's going to be a better outcome for patients. So we've taken that PRO, the Speedy tool, and we put it into a mobile phone app. We've got some algorithms that sit behind that. So when it's completed, then the family are either directed to, if we've got a low concern about their symptoms, they receive some management advice, and then it escalates up. If they get a red notification, we're asking them to pick up the phone and to call the hospital to speak to a clinician. So that sounds like it's, it should all work in theory, and that's great. That's nice and easy. Can't move the slides. So that, that on the surface we go, right, have we now addressed that problem? Is that Is that all we need to do? But of course, no, nothing is that easy in healthcare. And when we come to pediatrics, it's really back to this developmental stage that the child's at and all of the issues that, that surround that. So I just want to go through some of those. So we come back to those first principles about communicating with children. So of course, their developmental stage and their ability to communicate really comes to the forefront here. Children are not always good communicators about their experience, and we need to be particularly aware of the child who may be quiet or who may be, appearing to be very good and compliant. They may actually be the child that's really is experiencing heightened distress. When we ask children about how their treatment's going or how things have been over the past week, their recall bias is not likely to be accurate. They're more likely to report how they are in that given moment. We also know when we ask children, they're more likely to sort of remember the extremes of an experience, so something that was either really, really good or really bad. So while we want to include children's voices when we're developing all of these sorts of tools and these structured ways of communicating, we need to then think about, well, they need to be age appropriate. So something that's developed for a 5-year-old may not be appropriate for somebody who's older, maybe a teenager. And then we've also got the issue of children who may be nonverbal, or certainly younger children who can't respond verbally. We need the parents to then proxy for that child, and that brings a whole other set of issues there. So there's one tool that I use quite a bit in my research, the PEDS-QOL, which is a measure looking at child well-being. And that measure has 6 different versions depending on the age of the child, whether we're asking the parents to proxy for the child or not. And that then becomes really difficult when we think about implementation. Which version are we going to use? If we're building mobile phone apps, which version do we put on the mobile phone app? It becomes quite a challenge. So for a number of these reasons, traditionally, we haven't used PROs in pediatrics, and we've relied on the clinicians to be the best judge and use their clinician assessment of the child's outcomes. And this is, we see this not only in cancer care, but across a lot of pediatrics, that these types of measures are just not well used, and we rely on clinician judgment. But we know that this isn't the best way to do things. We're not likely to get a reliable response from all clinicians. They can't see some of those subjective issues that the child might be experiencing. And clinicians are going to bring their own bias to a situation, whether that's intentional or not. They're going to be coloured by their past experience of looking after hundreds of children with the same sorts of conditions, and may not recognise that a child has a particular concern. So this then really questions the validity of using of clinicians and relying only on their judgment. We also need to think about the treatment environment. When we're using some of these measures, we're generally doing this in the hospital. And most of a child's life is not lived in the hospital, but we're often asking them these sorts of questions while they are there in the waiting room or in a treatment room. And we know children are particularly fearful around procedural anxiety, so we don't really know what the interplay of that is and whether that's affecting some of the reports that we get. And then, of course, we need to consider our socio-demographics, and as we've heard in some of the other talks today, the need to have something that's culturally appropriate and available in other languages is so important, but that gets really difficult as well. I've had a student translate some measures into Thai, and while it was a fairly straightforward process to translate individual words, and the words are able to translate, the meaning gets lost. So, for example, one of the questions was asked about the impact on other children, and we were able to translate that, no problems. But when that was tested with some families in Thailand, they interpreted that as meaning other children within the whole community, not thinking that because they have a different concept from the developers of the tool who were thinking of a nuclear family with mum, dad, and some other kids. And this is very true for so many other cultures, and particularly our First Nations people who may think of a family as having a different sort of structure and involving wider community. Health systems was also another word that did not translate. It was interpreted as different body systems, so cardiovascular and heart and GIT, when we were actually wanting to ask about the processes and the way that healthcare is organised. So direct translation doesn't always work. And then we need to think about, education and income. And if we're building mobile phone apps, do people even have access to these sorts of resources? So these are all other complicating things. Back to parents, when we ask them to proxy for their child, and they often have to do this a lot in cancer care. So in the first place, they need to consent for their child to receive treatment and often to be enrolled into a clinical trial. And they need to complete measures as part of that process. When we've asked parents what they think about this, we get really varying responses. So some parents really feel that when we ask some of these questions, it heightens their distress. We're asking them to think about how distressed their child is. That's an additional burden for that family. It takes more time, it disrupts their daily life. They're not always comfortable with having to answer this type of these sorts of questions. Some families will say if they have an infant or a nonverbal child that they feel that they are able to answer on behalf of their child. They feel that they intimately know that child and they feel quite comfortable. And then other families will say, there's no way that I can respond on my child's behalf. I don't want to take away their agency. My child's experience is their own experience. So we have this balance between, protecting the child and then also valuing their own agency. So then coming to validity, and when we're talking about validity and the ability to measure what we want to measure in a reliable and valid way, it's been studied for decades and decades, the concordance between child report and parent report, or clinician report and parent report, or clinician and child report. And because there is always discordance, the child does often answer at the extreme levels of a scale, whereas a clinician might sort of be more moderate in their responses, and a parent will pick up again different items. There isn't generally a great concordance between different people answering. And so for that reason, there's been this consensus that the child report must remain gold standard, and that's the voice that we should listen to, and that parent proxy is useful, but should just be interpreted with caution. But I want to question that, and I'm not the only person. There's some references down there that are probably way too small to read, but there's methodological issues around that whole concept. So in the first instance, when we think about how have these instruments been developed in the first place, well, if a child has at all been involved in the development of them, they must be able to self-report in the first instance. So they're not likely to be children who are younger or who are non-verbal. There are actually quite a few measures that have involved the child and included their voice in what's important to them. So this then raises that whole issue around the validity of the measure in the first place. Is the measure really measuring what's important to that child? And then we've got that issue of having all different versions for different ages. And as a researcher, that becomes really difficult when you're trying to, sum up a measure on quality of life, and we don't include, 5 items out of that scale because the child's too young. And what do we do with that? And how do we then report those sorts of things? So given all of that, I think the whole issue around validity and the proxy validity really isn't that important. And I think we should be moving on past that and getting back to thinking more about what is important. When we think about child agency, we know that is dependent on their level of maturity, their ability to communicate, and also their role in society. And coming out of the social studies, we're seeing more emerging around that child's desire for agency isn't the most important thing to them, but having an interdependent life and a role within a community, within a family, is what's more important to children. And there's that changing degree of dependence and independence for different aspects of life. So agency has been reconceptualized in this light and thought of more as a continuum rather than being something linear that a child will just move along through with age and pop out the other end, that it's more complex, a relationship that includes the child, but also their proxies, wellness, and stress, how, considers how long the child may have been ill, their culture and communication norms within the family. There's also emerging research that's coming out that highlights how important understanding family dynamics is when we're looking at the child's distress, and that perhaps looking at child distress in isolation is not quite valid, and we need to also consider the parents or the family's distress. A meta-analysis of child and parent distress in childhood cancer looked at over 3,000 different dyads and found enormous concordance between parent distress and child distress. So this, raises the question, should we really be looking at the whole family unit when we're coming to think about ways of measuring these sorts of issues? We know that in practice, we like to do family-centered care is sort of at the center of the way that paediatric care is delivered. But when it comes to research, I think we've got a way to go to catch up and really recognize that we need to consider the whole family unit when we're also thinking about how we measure some of these things. So there's a new paradigm that's coming out, and the Speedy tool that I use in the mobile phone app has now been re-evaluated, and they're now advocating for co-completion. So having a didactic co-completion as being the new platinum standard. So not asking a child to complete something on their own, but having a parent or a proxy caregiver with them, or the clinician, and somebody doing it with the child, and that this can be a valid and reliable way to really get an understanding of that child's experience. It recognizes the importance of that interdependence, and it can be closer to the lived reality of that child's experience compared to a parent or clinician proxy on its own. At the same time, we're also seeing a shift in the literature where people aren't so concerned about concordance between single items. So can a parent get the same pain score as the child? Can they really estimate what their child's score is? Moving away from that and looking more at profiles of experience. So is a parent able to generally understand or generally report a child who's in a high or a low symptom profile? And that has been demonstrated to be accurate. And this is clinically important because it identifies those children who might be most affected and who we need to intervene for. And we're in the case where we can't have a child report because they're nonverbal or they're too young, relying on the parent's judgment to be able to decide, if a child has got a high or a low symptom profile may be important in our clinical practice. So we sort of now have sort of come full circle to where we were relying on the clinician, to then thinking, no, it needs to just be the child, to now recognizing that really it's probably all three voices that are really important when we're thinking about the health outcomes for children. So the discordance between child, parent, and clinician isn't the focus, but we value all of the voices that are there, recognizing that the child is, of course, the expert of their own experience, but the parent is be able to provide more context, and then the clinician also has a valuable role to play in terms of understanding where that child is in relation to other children. So in summary, these sorts of measures I think are important. They're one way of structuring some communication in healthcare and with an aim to improve that quality of care. We've got a shifting paradigm in the research with less less concern about the validity of proxy report, and more recognition of the child as an interdependent member of a family unit, and valuing all of those voices. And we need a lot more research to really look at how we can move these sorts of measures into practice and improve some outcomes. Thank you.
Thank you, Nat.